Namaste, myself Triveni Khurana, Assistant Professor, Faculty Physiotherapy and Diagnostics, JVM, Rajasthan. Today we are going to discuss about cerebral palsy. Cerebral palsy is a disorder of movement and posture that appears during infancy or early childhood, resulting from damage to the brain. The damage to the brain is permanent and cannot be cured, but the earlier we start with the intervention, more improvement can be made. Any non-progressive central nervous system injury occurring during the first 2 years of life is considered to be cerebral palsy. Cerebral palsy is a group of permanent but not unchanging disorders of movement or posture and of motor function, which are due to non-progressive interference, lesion or abnormality of the developing or immature brain. Cerebral palsy if the brain damage arises during one of the following periods, such as prenatal period when the conception to the onset of labor, perinatal period that is 28 weeks intrauterine to 7 days, postnatal period is first 2 years of life. After the age of 5, we speak of stroke of traumatic brain injury. Epidemiology. Unfortunately, it is difficult to assess and clarify the prevalence and incidence rate of disability in poor resource settings. Not only the prevalence of childhood disability is on the rise, and cerebral palsy is one of the chronic condition, but also life expectancies are improving, which increases the burden of cerebral palsy. Cerebral palsy is the most common motor disability in childhood. Etiology is very diverse and multifactorial. The causes are congenital, genetic, inflammatory, infectious, anoxic, traumatic, and metabolic. Injury to the developing brain may be prenatal, natal, or postnatal. As much as 75 to 80% of the cases are due to prenatal injury, with less than 10% being due to significant birth trauma or asphyxia. Most important risk factor seems to be prematurity and low birth weight, with risk of cerebral palsy increasing with decreasing gestational age and birth weight. Population-based studies from around the world report prevalence estimates of CP ranging from 1.5 to more than 4 per thousand live births or children of a defined age range. Recent advances in neonatal management and obstetric care have not shown a decline in incidence of CP. With a decline in infant mortality rate, there has actually been an increase in the incidence and severity of CP. Incidence in premature babies is much higher than in term babies. CP is more common among boys than among girls, and more common black children among white. Most of the children identified CP have spastic CP, including 77%. Over half of the children identified with CP, 58% can walk independently, 11% walks using a handheld mobility device, and 30% has limited or no walking ability. Many children with CP also do have at least one co-occurring condition. Incidence of CP has no decline despite improved perinatal and obstetric care, as said above. The type of CP has also changed. In the 60s, athetoid dyskinetic CP accounted for approximately 20% of children with CP. Today, only 5 to 10% have this type. This decrease is mainly due to advances in the treatment of hyperbilirubinemia. The increase of spastic CP is predominantly as a result of higher survival rates for babies. Risk factors in the prenatal: prematurity, low birth weight, maternal epilepsy, hyperthyroidism, severe toxemia, drug abuse, trauma, multiple pregnancies, placental insufficiency. In case of perinatal, these are premature rupture of membranes, prolonged and difficult labor, vaginal bleeding at the time of admission for labor, bradycardia. Postnatal risk factors are CNS infections, hypoxia, seizures, coagulopathies, head trauma. There is no way to predict which child brains will be damaged by one of these factors or what to extent of damage will be. None of these factors always result in brain damage, and even when brain damage occurs, the damage does not always result in CP. Classification: hemiplegic rigidity affecting one side only, although lesser impairment of the apparently uninvolved limb was frequently observed. Paraplegia affecting both legs more than the arms, and generalized rigidity. If both sides are involved, it may be spastic bilateral. If not, it is spastic unilateral. Tone related, it is dyskinetic CP. If tone varying, if not, that not classified. In dyskinetic CP, there is reduced activity tone tends to increase, called dystonic CP, and in underdyskinetic CP, if increased activity tone tends to be decreased, then it is known as chorioathetotic CP. Other than spastic and dystonic and chorioathetotic, ataxic CP is also seen. What is spasticity? Spasticity is defined as an increase in the physiological resistance of muscle to passive motion. It is a part of the upper motor neuron syndrome characterized by hyperreflexia, clonus, extensor plantar response, and primitive reflexes. Spastic CP is most common form of CP. It has at least two of the following symptoms, which may be unilateral or bilateral. These are an abnormal pattern of posture, increased tone, Babinski sign. Traditionally recognized three types of spastic CP are hemiplegia, diplegia, and quadriplegia. Dyskinetic CP, it is the abnormal movements that occur when the child initiates movement. Dysarthria, dysphagia, and drooling accompany the movement problem. Intellectual development is generally normal. However, severe dysarthria makes communication difficult and leads the outsider to think that child has intellectual impairment. Sensory neural hearing dysfunction also impairs communication. Symptoms are abnormal pattern of posture, involuntary, uncontrolled, recurring, occasional stereotyped motion of affected body parts. Ataxic CP, ataxia is a loss of balance, coordination, and fine motor control. Ataxic children cannot coordinate their movements. They are hypotonic during the first 2 years of life. Muscle tone becomes normal, and ataxic child become apparent toward age of 2 to 3 years. Children who can walk have a wide base gait and mild intention tremor. Dexterity and fine motor control is poor. Ataxia is associated with cerebral lesion and combined with spastic diplegia. Most ataxic children can walk, but some need walkers. Symptoms include abnormal pattern of posture, loss of orderly muscular coordination, so that movements are performed with abnormal force, rhythm, and accuracy. What is mixed type of CP? Children with a mixed type commonly have mild spasticity, dystonia, and athetoid movements. Ataxia may be a component of motor dysfunction in children. Ataxic and spastic often occur together. Spastic ataxic diabetes is a common mixed type that is often associated with hydrocephalus. Diagnosis of CP. One of the main causes of childhood disability with many different signs, symptoms, challenges. There is no one test to confirm if child has CP or something else. There is no blueprint of intervention for a child with CP, and each child is different and unique. Classification of gross motor, fine motor, and communication will help medical professionals and the family to better understand the abilities of the child and what to focus for an intervention. This diagnosis is based on clinical description, which is based on result of biological test or on imaging findings. Consequently, diagnosis can be subject to some degree of variability. This means that two pediatricians may disagree on a diagnosis of CP for the same child. It is sometimes difficult for even professionals to differentiate between bilateral spastic CP and dyskinetic CP. Mortality in CP is extremely variable. Life expectancy is normal in most diplegic and hemiplegic children who receive adequate medical care and have strong family support. Some severely affected quadriplegics die of malnutrition, infection, and respiratory problems before reaching adolescence. In some very poor and poor resource areas, children with CP may not reach the age of 5. While selecting the outcome measure, psychometric properties should be considered. In the selection of assessment method, it may be beneficial to consider dimensions of International Classification on Functional Disability and Health Child and Youth version. Detailed information should be received from family in all issues related to the children, including family history, prenatal, natal, and postnatal period, chronologic, corrected age, other accompanying problems, developmental story, adaptive equipment used, therapy, approach applied, medication taken, and education status of family. Observation of reflexes is important to illustrate the severity of the influence in the nervous system, and observation of balance and productive reaction is important to support motor developmental function. CP is a non-progressive CNS problem. Emerging physical impairment, functional limitations change the therapy approach applied to children during growth and with effect the environmental condition. So, assess motor development, functional skills, activity limitation for determining the current state of children. Used batteries for this purpose, example gross motor function measurement. Others, activity scales for kids, child health questionnaire, Gillette functional assessment questionnaire, functional mobility scale, pediatric evaluation of disability inventory, pediatric outcome data collection instrument, functional independence measure for children. Spastic type is most common among CPs. Therefore, spasticity is a major problem encountered most frequently by pediatric physiotherapists. Various physiotherapy methods can be effective in mild tone problems. The most affected muscles from spasticity in children with CP are gastrosoleus, hams, rectus femoris, hip adductors, and psoas in lower and shoulder external rotators, elbow, wrist, and finger flexors, and forearm pronatus in upper extremities. There are various clinical scales, biomechanical assessment tools, and neurophysiological assessment methods to assess spasticity. But past clinical scale modified Ashworth, Tardieu, in addition, modified composite spasticity index, Duncan-Alley test, New York University tone scale, and hypertonia assessment tool can also be used. Other than these, manometer sensors, Wartenberg pendulum test, dynamometer, goniometric measurement, robotic supported instrument are also used for biomechanical assessment. Muscular force can also be assessed as an isometric, isotonic, and isokinetic. For muscular strength assessment, patient should cooperate with the assessor and target muscle group must contract maxima. Children with CP are prone to develop musculoskeletal system deformities. In addition to the major problems generated by CNS lesions, CP, the musculoskeletal problems can also be assessed to detect and prevent from deformities in early age. Thank you.